Okay, good morning, good afternoon, good evening to everyone joining us from all over the world. I bring you warm greetings from the beautiful city of Kumasi, where I am currently as a research fellow with the Global Health and Infectious Diseases Research Group at KCCR. It is my great pleasure to welcome you all to this session as we bring together to reflect on this year's theme, Health for All, bridging the gaps and advancing universal health coverage. I want to extend my sincere appreciation to the CEO of the Global Health Insight and Education for entrusting me with this moderation role for this timely and important conversation. Today's discussion is particularly timely as the world continues to confront persistent inequalities in access to healthcare. Globally, there have been some significant progress which has been made. However, in low and lower middle income countries, we continue to face barriers to essential health services. And this theme calls on all of us to renew our commitments to ensuring that no one is left behind. Once again, you are all welcome, and I look forward to having an engaging and impactful session. Thank you very much. I think the CEO will give a brief introduction of the organization and purpose of the gathering. Thank you.
Thank you.
Maybe let me just continue. I would want to give a short overview of the World Health Day. So, by way of a brief overview, World Health Day, as we know, is celebrated annually on April 7th to mark the founding of the World Health Organization, which kicked on in 1948. And each year, it highlights a priority area of global public health, drawing attention to very key issues and mobilizing actions across countries and sectors. At the heart of today's theme is universal health coverage, which means that all individuals and communities receive the health services they need, ranging from health promotion, prevention to treatment, rehabilitation, and palliative care without suffering any financial hardship. Achieving this requires strong health systems, equitable policies, and sustained collaboration across stakeholders. As we proceed, we will hear from experts and practitioners who will share insights, experiences, and practical strategies that will help us bridge the gap in healthcare delivery, enhance universal health coverage in our respective sections. It is my distinct honor to serve as your moderator for this session. So today we are privileged to have with us a very remarkable and very strong panel drawn from Ghana, where I am, from Uganda, from Nigeria, and all the way from the United Kingdom, each bringing a wealth of experience across clinical practice, research, and health systems, strengthening. So together, we're going to explore some very practical, context-specific pathways that is going to help us advance universal health coverage with a particular focus on low and middle income countries. So I introduce our panelists now. We have here Dr. Innocent Aisiga, who is a medical doctor and a public health researcher from Uganda. He has extensive work spanning neonatal care, antimicrobial resistance, and health system strengthening, and he has a very great body of over 35 peer-reviewed scientific publications. Sorry. Then we have Ruth Yuga and Dunaga, a well-experienced research laboratory scientist from Nigeria. She has a deep expertise in microbiology, infectious diseases, and community-centered health interventions. And we have all the way from UK, Prosper Asafo, who is a senior public health officer with the Ghana Health Service and currently a Master of Science student at the University of Hull in Britain with great experience in public health systems. And we have here also Fatih Ibrahim, who is a nurse in charge at Eninewa Medical Center, bringing in invaluable frontline clinical leadership and direct patient care experience to this conversation. She has over a decade worth of experience and exposure, both in the clinical and public health space. So my panelists, you are all welcome. To set the ball rolling, I would want to start with Dr. Innocent. So Dr. Innocent, kindly tell us, what does health for all mean to you in your current context and role?
Yes, greetings everyone who is watching us from wherever you are. Good morning, good afternoon, good evening, and we want to thank you for taking this opportunity to join in. Thank you so much, Dr. Jonathan, for that question. It's a pertinent question for me as a public health practitioner, and I believe health for all is when everybody can access the right services at the right time when they are rightfully needed, so that their standard of life is better at any one point or at any one moment. Yeah, so I would think it would encompass a lot of things, such as healthcare access, such as the ease to access these services, and this is very critical in ensuring that their livelihood and standards are actually to the best that they should, because eventually this translates into their productivity, which is eventually reflected into the economy, both on a personal scale but also on a national scale.
Thank you very much. That's very powerful. As a follow-up question, so from where you sit, how close or how far are we from truly achieving universal health coverage?
Yes, thank you for that follow-up question. Well, universal health coverage is quite a complex situation that we can talk about. And, quite a lot of people, you hear them speaking about universal health coverage, but when you bring it from the context, for example, from the World Health Organization, it has set a metric of 65%, because it's measured in percentage points from 0 to 100. So it's the current threshold is set at around 65%. But when you look at some of the individual communities, nations, and the continent at large, you realize that we've not yet hit that 65%, which is the threshold. Ideally, 100% would be the absolute, but then we are still not yet hitting the 65, and that's one of the key things that, we need to keep attending to. For example, when you look at the context of Uganda, where I am currently, the World Health Organization has ranked Uganda to have achieved 54% of the universal health coverage. That is still below. But if you compare it with other years, for example, in the year 2000, the universal health coverage was at around 24%. So you can see that within a span of 26 years, we've almost, doubled yeah, the Universal Health Coverage Index. So it's very pertinent that even beyond the metrics that have been set by WHO, we come back to the ground and evaluate, are people receiving the care they are supposed to need? Are they getting the medication, for example? Are they getting the testing? Are they seeing a health worker? Because at the end of the day, all these attributes are very pertinent in achieving universal health coverage. If I am in a community and my next health center is around 60 kilometers, that's a very big barrier for me to achieve, universal health coverage. So in as much as we are making progress, significant bottlenecks are still there, especially within the underserved regions, within the rural areas. You find that health service products, amenities are still very limited. There are quite a number of projects and activities that have been running, but you reach, for example, a health center 3, and they do not have medication. Unfortunately, this is the real experience that is happening. So in as much as the overall metric is demonstrating that we are making progress, there are still some bottlenecks that are still hindering the overall progress.
Excellent, excellent, excellent. Thank you very, very much, Dr. Innocence, for the powerful and grounded starting point. I would want to go to Pati, who would share on the barriers to access, which you touched on. So I would want to hear your thoughts on the next question, given your front vantage point. So in your day-to-day experience, what are the biggest barriers preventing people from accessing quality healthcare in your setting?
Thank you very much, Doctor, for that question. For me, I think this is really where the complexity of universal health coverage become very clear. When we talk about barriers to accessing quality healthcare in my setting, and I think more broadly across many low and middle income countries, we are not dealing with a single issue, but rather a combination of interconnected challenges. So for me, I think I would want to start with financial accessibility as one of the barriers. Even within our setting here, where we have health insurance available, uh, access is not always guaranteed. Enrollment does not necessarily means effective coverage. You have people who would enroll and at the end of the day might not have renewal, so they lose coverage. So it doesn't guarantee that the person has what a coverage. People still face out of pocket payments due to sometimes payment of medication, which I think earlier Dr. Bain made mention, and even transportation also from wherever you are to the facility, or either even if you are supposed to even renew the insurance where you are supposed to travel to. All right. So all these things are some of the factors for me that cause people not to really access health timely. Another aspect that I would want to look at is the geographical and then the infrastructural barrier that we have. For many people, especially within the rural areas, healthcare facilities are simply too far away or inadequately resourced. So poor roads, limited referral systems, all contribute to delay in accessing health. All right. And my third, I think, maybe a point I would want to critically even look at is the health system quality and the trust that people do have for the system. If people perceive your health care to be poor, or maybe the person experience certain kind of attitude from healthcare provider, another time you see the person trying to look other way in what trying to assess, I don't know whether I should still call it health, because of either the treatment the person went through at a specific place. So for me, this means that access is not about availability. It is available, at least to some extent, but also the confidence in the system. So when people are not so sure about what they will get within certain systems, they tend not to show up at all when they need it. I happen to work on around NHIS and then digital health. Ghana introduced mobile renewal system just to solve certain barriers such as travel long distance to renew insurance and other things. But guess what? Because of access usability gap, I tell you, people are not using that system. Why? Because digital what? Literacy gap, trust issues for the system, and unequal access to technology. So even when solutions exist, they don't always translate into access for everybody. So for me, I think my initial my submission would be on these few points that I elaborated. Yeah.
Thank you very much. Thank you. I like the point you raised that we should have confidence in the system, and that is a big challenge given the financial and geographic barriers that you've mentioned. Also, I would want to touch on beyond the financial side of things. What are some social or cultural factors that limit healthcare utilization?
Okay. So I think that beyond these financial barriers and then the digital access, I think one of our major issue has to do with health belief and then cultural practices. All right. For instance, in some of the in my should I say in Ghana here, people often interpret illness or look at it with the lens of what spirituality and then cultural beliefs. So these things end up delaying them because they would first want to assess the care or health from whatever they believe is the cause of the illness. So if they think it's spiritual, they would want to either go to um, uh, spiritualists, or they want to go and see a pastor and other things. All these things end up delaying the person in assessing care early because of how they believe or what they believe is happening. Now, again, I also want to look at maybe health literacy. Okay, how do people perceive or understand some of the symptoms that okay, does it really strike them to seek health early? So the understanding of what health is, what those signs and symptoms also means, are also another aspect that maybe we have to also really look at very well, because it is driving people away from assessing health early. People will see maybe a child with mumps, he has this swollen cheeks and everything. Before you see them putting different colors on the cheek because they believe that it is something else that is what's happening to the person. Meanwhile, there is a very simple, straightforward treatment within healthcare. But because they believe it's something, or they have no idea exactly on what is happening, they tend to look elsewhere for treatment. Another aspect I want to look at is the gender dynamics, probably that also happens within most of our settings. They build due to sometimes cultural and then religious belief. Some women are not autonomous when it comes to taking decision regarding their own health. They would have to wait for their husbands or somebody to seek permission, especially when it deals with maternal health care and reproductive health services. You see them delaying. A woman be pregnant, started bleeding. but she's in the house waiting for her husband to give her approval. If she calls and she doesn't get access, she will still stay home till somebody tells her you can go. So all these things are some of the things that, for me, I believe are causing some of the delays that we are experiencing. Another aspect that impacts health access is stigma, especially with people with certain kind of infection, HIV, and then even tuberculosis, mental health. The moment you go, the entire community, or if you are not careful, the entire household are tagged that you are from a house of people with mental illness. So they tend to hide the person. They tend to take the person to these spiritualists and other places to seek help. So by the time they realize that no, it's beyond this, you realize that it is far what advanced. So they will come to the facility and it is delayed. Okay, so as I mentioned earlier, for me now, my work that I do has to do with, though yes, I'm at the hospital, but I still also work on digital health and insurance renewal and other things. So for my other aspect of it, also that cause delay is the accessibility issue with even digital technology. A lot of people do not even have access, although we've provided a short code that people can renew their insurance on. Because of the know-how, technological survey is very, very high. So a lot of people are not able to access and renew their insurance on time. They get to the hospital and you realize that the insurance is not working, something that can easily give you access. Then later on, if there is anything else to be added, you don't even have it. Although there is that command, or should I say that order from NHIS, that whoever comes in has to receive first aid, whether the person has insurance or not, or should I say even from the health perspective. I believe that it doesn't actually work always, especially with some of the private hospitals. If you end in the government hospitals, you are lucky, yes, you get those access, they stabilize you, and if there is a need, you are referred. But if you end up in some of the private hospital, a private man is looking at the money he's making, what he's going to use in paying his workers, how he's going to restock his medication, how he's going to maintain his equipment. Okay, so for him, yes, if you are not lucky, you will not get the service you deserve. And these things are all causing the delay in access, and they are becoming a lot of barriers to us. Thank you.
Thank you very much. Thank you, thank you, thank you. That's very, very insightful and loaded. I would want to jump all the way to Nigeria, Ruth. For the benefit of our brother audience, the last time I checked, Nigeria alone has over 200 people living in one country. That's a lot for the continent.
200 million.
So kindly explain to us universal health coverage in very simple and accessible terms.
Okay, thank you everyone for having me on this graceful platform. And thank you to the other panelists, Dr. Ayesiga and Madam Fati. Yeah. Universal health coverage, I mean, they've talked on it, they've touched on what it entails and how important it is. So to define it simply, universal coverage, I would say it's an idea where everyone within let's use a country, for example, is able to access high quality healthcare services when they need it, however they would need it. So looking at, it could be a mother in an IDP camp, from the insurgency attacks in Nigeria, we have over the past couple of years, many IDPs have come up. So universal health coverage should provide healthcare for a woman in the IDP camp who requires or needs antenatal care, for example, a child who needs, an urgent health care need. So all of this access to healthcare when and where is needed must happen without the person getting poor. So that is accessing the healthcare and ensuring that at the end of it all, the person doesn't end up being broke, to put it simply. You know, in our continent, the African continent, Nigeria, as our moderator has rightly said, is the largest of the different countries in Africa, has suffered a great deal. Looking back at during the COVID-19 pandemic, for example, that brought to life the reality of how far we've gone in terms of health, universal health coverage. And in my context as a laboratory scientist, I would say that universal health coverage must happen in a way that it's not only accessible, it must be affordable, and also that this care doesn't make one, face financial hardship at the end of the day. Yeah, thank you.
Excellent. Excellent. So we should be able to have access to health without suffering financially. Just a follow-up to that. In your view, what are the key components that must be put in place for universal health coverage to truly work?
All right, thank you so much. Once again, so for UHC, shortly to really work, we need an interplay between different systems, in within the health system to work together, not in silos, but together. Efforts needs to come from different aspects of the health system, looking at the financing health system, for example. When you talk about budgeting for a country, the healthcare budget for a country, an annual healthcare budget for a country, you're looking at ensuring that this budget not only covers all the needs for healthcare for that country, but also ensuring that the funding comes as is expected. So you notice that a very big figure has been put for funding for the year, but at the end of the day, only a fraction of that amount gets disbursed. So at the end of the day, having to manage funds within the health system. And so if that is not well taken care of, if good budgeting is not done, at the end of the day, we will not achieve universal health coverage. And also, in line with that would be ensuring that within the health system, we have a functional health system governance structure that is not only leading within the health system, but also ensuring that it's so in all the decisions that is made, all the policies that are being developed, it should be patient-centered. It should be towards ensuring that healthcare is improved, well-being is improved, and not just for selfish interest. And also, it should, that same governance or leadership within the healthcare system has to ensure that it is trustworthy and accountable where it's required. Also, for universal health coverage to work, we must have a healthy workforce. So you must have doctors, nurses, you must have laboratorians, you must have the biomedical engineers. Everyone has to be available with the right capacity to bring to life the idea of universal health coverage. Also, my colleague, Madam Fati, had talked about her own experience on the front line as a nurse. So looking at the presence of a strong primary healthcare system to also ensure that universal health coverage is successful, where proper public education is administered, proper nutrition, access to clean water, sanitation and hygiene, access to maternal or child health care services, and also immunization, and also access to laboratory diagnostics. For example, like in my context as a laboratory scientist, so I see that within my country, Nigeria, for example, many of our our health facilities um, exist without, you know, capacity to actually carry out diagnosis. So you see a very big hospital, but then they don't even have laboratory services. So how are you diagnosing health issues? How are you administering treatment? Are you just carrying out guesswork? So if we don't have a proper workforce, we don't have the right services, universal health coverage will still be a myth for us to achieve. And in addition to all that I've mentioned, for universal health coverage to work, we also require very high quality data systems that not only generates data and evidence for them to end up in paper policy documents only, but those data and evidence that have been generated is being translated to, people-centered, patient-centered policies that will bring about improvement in the health of the population. Thank you.
Thank you very much. Thank you. You touched beautifully on the we having a healthy workshop and we strengthening our health system. So building on those very important and insightful points you've raised, I would want to go all the way to UK. So Prosper is on. So Prosper, if you may, who are the most underserved groups in our health system today, and why are these individuals the underserved groups?
All right, thank you so much, Dr. Jonathan. This is a very important question because we cannot be talking about universal health coverage when we leave out certain people. The term in itself, universal, means that it must touch on everybody. As the earlier speakers have mentioned, Dr. Ayesiga mentioned lack of essential medicines as is stressed on, or is essential medication in Uganda. And I'm very happy that Fatih spoke before me because she mentioned a lot of things that I had been thinking about or reflecting on when I was preparing for this webinar. Yeah, and she talked about delays in the health system and health belief model and things like health seeking behavior in the population as the barriers that we still face in Ghana's health system. And I'm also happy that Ruth mentioned a lot about those as well. Yeah. But for vulnerable or underserved groups, I think that it's evolving. It keeps evolving. In our context in Ghana, vulnerable groups, I think they are not just a specific group of people that are sitting there that we can just say these are the vulnerable people forever or the underserved group forever. Generally, we can talk about those living in poverty. We can talk about people living with disabilities. We can talk about people's geographical that they are living in, and these could contribute or have been contributing to lack of access. But thinking about the main components of universal health coverage itself, speakers have mentioned, accessibility, affordability, and of course, we should also be talking about quality. I think Ruth really touched on quality. Yeah. So for those who are underserved in Ghana, people living with disability, and the Ghana Statistical Service found that 7.6 people of our population are living with disability. But our health facilities, we are talking about access, but at least these people, they needed access to our health facilities. We have technologies in our health facilities that making it accessible to these people. Even our infrastructure, when we are building hospitals, do we include or do we have in mind people with disability, for instance? And as for poverty, our context in a low middle income country, we cannot talk about underserved population and leave out people living in poverty. The earlier speakers keep mentioning how that financing is the main challenge in universal coverage. Even though Ghana's population, about 70% of the population, have access to or are enrolled on our national health insurance scheme, there is still issues, pertinent issues. Party mentioned some of them, and we need to consider all this when we are thinking about underserved people. Just to mention another thing related to this before I draw the curtain on this question. Ghana's strategies to achieve universal health coverage have included adoption of the community health-based planning and services, the CHIP, during Ghana's health reform in the mid-90s, where the CHIPS compounds have become a main strategy for increasing access. So we are dealing with access. But I've been thinking about affordability, and I've also been thinking about quality a lot. Yeah, so these are things for us to reflect on as we consider those who are served our health system. Thank you. A lot of things are going through my mind right now.
Thank you very much, Prosper. Great, great, great. You touched on accessibility and how that is supposed to be affordable. And in addition to the fact that it is accessible, you touched on the quality of the services that would have to be given. Your next question will be to how do we ensure that health for all truly includes all the marginalized population? How do we go about it in a more practical and operational manner? Thank you.
Yeah, thank you very much for that question. This still brings us back to the main components of better health coverage that we have, chiefly among the affordability, right? To ensure that we have an inclusive healthcare system. We cannot overlook affordability. yes, I mentioned that poverty is one of the reasons why we have underserved population. And Patty, I'm still remembering Patty mentioned that we have the health insurance, the strategy to deal with issues and the structural inequalities that exist in our health system, for marginalized to also be able to have access to the care that they need, and in a quality manner. Yeah. So to ensure that all this is addressed in our health system, um, we need to ensure that we have policy and integrate touch into our primary care and train health workers to understand disability services. And so we need to be increasing the trainings of professional areas, physical therapy, mental health as well. Then to address the social or the structural inequalities, we need to invest in social programs that provide opportunity to um, help families the extra financial support that they need, because there is still a lot of pocket in the system, even though we have the still certain essential service system that require out of pocket. And I'm happy about the current government's introduction of free universal health service, the Mahama Care, popularly known Mahama Cares, which was launched recently at the Shai Osudoku Hospital. If I'm right, I think it was launched there recently. Yeah, and how the president reaching it to ensure that certain critical issues have support from this to a certain extent. We are calling it free, but we know that it's not entirely free from the onset. Yeah, but that is a very good strategy, which means that we are thinking about marginalized population. We are thinking about the poor in, um, in, among our population. Number people who have certain critical issues, kidney diseases, and all that, who do not have the means, the financial support from their families to be able to assess dialysis and the treatment that they need, to at least uh, live on a little bit more. The government is stepping in. Such policy, such policies are what we need to be able to support the vulnerable in our. Thank you.
Thank you very much. Thank you. Thank you. Very, very insightful. I would want to bring. Okay, sure.
Yes, I just wanted to add something, and I think
Definitely.
that you touched on a lot of things. Very, very good. Um, I may sound a bit biased, but because I have slight working with NHIS, I seem to understand what they do a lot. Because to help these vulnerable ones also, there is an exception groups or people that are exempted even from paying renewal fees and other things. But I tell you, I think challenge has to do with even them knowing that they are exempted.
Mm-hmm.
So awareness creation, I think, is also something that we really have to work on. It is there for them, but I tell you, they come to the hospitals day in and day out. The insurance is expired months. They don't even know. All right. And then I think that basically, I think that is that the awareness, we have to really focus on that. And we can also look at prevention. In fact, before even, the person becomes sick, what are we actually doing to make sure that these people are, in a way, um, there is some kind of reduction in the risk of becoming even ill or infected with certain things, early detection, screening, and other things. So I think we should be able to have some programs running, going down to the communities to be able to engage with them so that we tend to, or we'll be able to identify those ones early. And then the ones that need to be taken care of will be taken care of. The ones that are preventable or people are cautioned, they are also cautioned. Because I know that some of these diseases do not just happen within a day, they take time. But we didn't catch it early. Who is screening who? Who is alerting that you should be careful about this? Though I know, yes, a lot is also going on TVs and other things. Yes, TVs are available these days, but I tell you, there are some areas you go, even they don't even have the lights, left alone to get the TV to see the things that we are putting on the TVs. So I think that we should be able to go down to certain communities to preach this gospel so that we can look at the prevention aspect. Thank you very much.
That's
Thank you very much. Sure.
yeah, that's very important. Just in less than 1 minute, let me just follow up.
Definitely. Sure.
I think that we could also use the grassroots workers in our primary healthcare system, right? The
Yeah.
community health workers. I know that are well trained when it comes to health promotion, health education, and things like that. Yeah, so we still have people who or we still have awareness. Sorry, we still have awareness issues in the system. We just need to intensify education, um, or create awareness using these grassroots people. I think that organizations like this, uh, organizations like this, we could also take on ourselves the responsibility of, educating the grassroots people. I remember there was a time so many years ago, that should be 2017, I guess, where I traveled to the northern part of the Volta region. Yeah, it was on a different mission, but I just saw, as a health worker, I saw a child with a certain condition. And we are talking about, my former question was about vulnerable people, underserved groups, and things like that. And children cannot be left out when we are talking about vulnerable groups. The elderly cannot be left out. But I saw this child who had this condition. I I cannot tell. Maybe if it was Dr. Yesiga, probably he could have had some insights or something, some sort of diagnosis, probably. Yeah. But I was just touched with compassion, and when I came back from that place, I raised some funds, and I went back there. What the only thing I did was to educate the parents that this thing can be cured. Let's take this child to register him on the national health insurance. We did that, and then he got his national health insurance that same day. and was taken to the hospital that same day. And I followed up, and the wound was healing. The wound was healing. So sometimes I think that we need to adopt community approach. We are doing things like these webinars discussing the issues that are around. But if we could also take a community approach to some of these things, we'll be able to educate more people on the services that are available to increase access to those services.
Excellent, excellent, excellent. Thank you very much for that charge. I would want to come again to Madam Fati, who would, so we are returning to the theme, which is often underestimated, community engagement. And Prosper said we should go to the community. So Madam Fati will take us to the community. So what role should communities play in shaping their own health systems?
I think that the first thing that we as probably health workers should do is to make sure that we involve the communities in decision making and planning. Okay, so that the health system can work better. If we don't involve them, we may end up even missing exactly what they need. Okay, so we are supposed to involve them so that whatever that we are bringing out would reflect their needs, priorities, and then the reality of the people that we are intend to serve. But if we sit behind and decide that, okay, we think that this is what they will need, I tell you, you will get there and you will be surprised that they might not even patronize it. Okay, but if we involve them, they will own it and they will tend to even protect it. At the end of the day, if it's a project, a time elapsed and I mean your money is finished, okay, you are supposed to leave. They will own it, protect it, and continue with it because we involve them. So the first thing as um, health workers we have to do is to involve them so that we empower them to be able to what own whatever that project it is that we want to bring to them. When we are able to involve them, the interventions are usually more relevant. They are more accepted to the people, and ultimately it becomes more effective. Another thing I think that they should be able to do for us is to help us in health promotion, which I think earlier we made mention of. The people trust them, the people they live with, okay, like the leaders within the communities and other things. They trust them, they believe them. So if we are to involve them in some of these things, they through their peer groups and the community networks will be able to preach to them, okay, the language they understand, the dynamics they believe in, so that it will help in improving this awareness that we are talking about. It even will address some misconceptions that are within the communities which they are really aware of. And then we might be able to encourage these people to seek healthcare early. Okay, so community engagement is something that as health workers, we should never ever underestimate. I quite remember as I keep referring to NHIS issue, we thought that insurance renewal has to do with money. So the idea was for us to look at how best through research we can introduce a savings wallet where people would save money and be able to what renew their insurance. But trust me, when we went to the people on the grounds, they were like, no, the money is peanuts. It's not about the money. It's about really not knowing when to renew. Because as we speak, the insurance is on it's renewal on mobile phones. Okay, at first they were giving card and the date is behind it. So at least even if you forget, you look behind it and then you remember the day. But this is the case now. The cards are no more. You renew on using your phone. So they tend to forget about the exact date that they would want to renew their insurance. So they were rather what? Seeking for reminders. And the ones who were having challenges with how to even navigate the system, go through the step-by-step prompt to be able to renew their insurance, were asking us to find a way to make it what? Automatically renewed for them. Okay, so I'm giving this example so that we intend to appreciate when you engage the people who are going to use the intervention that you intend to give them. Involving them is the best, because at that time you will be able to do situational analysis. You know what actually they need. Okay, so when you bring the product itself, they would accept it and will be able to what? Use it. Then again, I think another aspect is uh, well, communities, when they are empowered, will be able to seek for accountabilities from even the health system. If they know, as we speak, there are people on NHIS, when you go to the hospital, maybe your card is free. When you have malaria, you need anti-malaria, you should be given some paracetamol and other things. Because they don't know, there are people who will go there and then they are charged. Yet they take their insurance and still use it for what? Claiming their insurance money from health NHIS. But if these people are aware of what they need or what they are expected to get by virtue of them having health insurance, they can demand accountability from the health system, from the people who will be charging them probably double. Because once you are charging NHIS and you are taking money from the individual or the patient, it means that you are taking should I say, money for a single service that you are providing. So that is also another aspect for me that communities can actually support this um, health access or increase awareness. Then again,
Yes.
from me, my point, as I said, from my perspective as insurance perspective, communities help in bridging a gap between the system and the users. Okay, especially through community health workers, as Prosper mentioned earlier. We are supposed to make good use of them. Then we have local agents. If you have champion of a certain within a certain community, let's say you are trying to handle something about TB, and then you identify a community member as a champion or as a agent within there. It helps because the person vibe with them, they understand the person. Okay, so it makes it a bit easier for them to be able to get them to understand. The same way these agents can get people to even enroll on NHIS and other things. So getting community members is also another aspect, or should I say, a strategy that will help. But without us involving them, they will not just wake up and then what? Decide to get involved. So we have to take the initiative to be able to involve them so that they can also what? Feel empowered and then what? Join us so that we can all walk this path of trying to improve access to healthcare. Thank you.
Thank you very much. Thank you for pushing that we should
Absolutely.
involve communities in our plans. I think Ruth wants to add.
Yes, thank you so much. Thank you so much, Madam Fati. It's been very insightful listening to you, and also it's interesting to even from what
Prosper.
our brother earlier, when Prosper, yes, the testimonial you gave about the boy, who you were able to get enrolled on NHIS. I think that was brilliant. That's the whole essence of why we do what we do. To add to the role of the communities, even in driving, healthcare, I would say from the health research perspective, you discover that when you design a research and you involve the communities. Take for example, there was a project it's still ongoing. It's on combating antimicrobial resistance in West Africa using data science. One aspect of that project involves, visiting households And the essence of visiting households is to take samples, which would then be analyzed in the laboratory to understand the trends of transmission of multi-drug resistant multi-drug resistant pathogens within the communities. And from our experience, involving the community played a huge role in encouraging acceptance, even when we needed to go to these households to engage them. Not only did we take samples, we used the opportunity to also educate parents, caregivers on, the dangers of improper use of antimicrobials, which is, if we were to begin to talk about the issues around AMR, I'm not sure we'll leave here today. But just to also add, even though it's away from the NHIS we've been talking about, this is still part of universal health coverage. Infectious and the aspect of infectious diseases and the growing threat that AMR has become within the global health space. So yes, I agree with you when you say communities should be involved, because then they feel valued, and also at the end of the day, when you need to come back with an intervention that they were part and parcel of planning, the uptake implementation would move smoothly. It would be smoother than because they were involved from the beginning. Thank you so much.
Thank you very much. Thank you. Greatly, greatly, greatly appreciated. Right on point. So coming back to Fatih, a follow-up question will be, how can our local leaders and community structures that we've built actively improve healthcare delivery? What are the things that they can do to improve healthcare delivery? Thank you.
Oh, okay. So when you look at our local leaders, whether traditional or religious or the civic, for me, I think they play a very influential role in increasing awareness or uh, improving access to healthcare if they are really involved in whatever that we do. They can build trust in healthcare intervention and services. So within their communities, as I said, they are the ones that are being respected. They are the ones that give even orders sometimes. Let's say for me today, if I have my imam with me, and maybe there is something that somebody believes that it is not true. If I have, even if I don't believe that person, and my imam during our sermon will come to me or would stand within the congregation and start explaining the very things that I believe were not true. Usually it comes home, it drums home because it is from somebody you trust, somebody you believe in. All right. So that is another aspect of it. And then again, they are able to mobilize people for us to be able to have, even if it's immunization or any of these health programs, so that today they will just end up telling you, oh, there is this program that maybe this hospital is running. I would want all of us to gather around and then we'll partake. In fact, you will see them coming in because you had a leader or an influential person trying to make sure that these people are what are around. Then again, when we are able to really involve these people, they address cultural barriers and misinformations for us, okay, using their influence to shape positive what behaviors. These are some of the things they are able to do for us. So one of the important aspects of it all is also when they are also empowered. I keep going back to when they are empowered, when they are involved, because you can have some of the leaders, they are part of a committee, health committee within a certain suburb or within a certain municipalities. You see them at meetings and actually you will not end up giving you anything or saying anything. But if they are, the selection is done right and they are empowered or they are enlightened about some of these things, they end up what advocating for better service for their people. They will go to this meeting and be pushing. I quite remember I was a member of a community, for Chrome here where I stay, and actually we meet usually in a month, every month, once in a month. There was this imam that was part of this project, and one of the things that I think somehow we overlooked, because we were only thinking about how people will be vaccinated, why are vaccine hesitancy, what about this man came in one day and was like, my headache is the road, look at this pothole, this one is not a pothole, it is a manhole, and I want you people to fix it for me. And then it dawned on all of us, because we were all thinking about something different. But this man came in and he was like, I want this. Because these things that we are ignoring, if anything should happen, it is the health systems that are still also going to suffer. And if you're lucky, even if it's one person, let alone if it is an accident, it might not be just one person. So involving them, I think, is very good. They bring other versions that we don't even look at sometimes, or sometimes we ignore. So in many of these settings, especially Ghana, these leaders are often the link between the formal sectors and everyday community life. When they are actively engaged, health delivery becomes more responsive, more inclusive, and more effective. So ultimately, for me, strengthening health system is not just about infrastructure or policies. No, it is about how well we engage the people. Those systems are meant to what? Serve the people that we are interested in helping. We are expected to what? Involve them. Because when communities are informed, involved, and empowered, they don't only use health system, they help make them work, even when we are not available. Thank you.
Thank you very, very much. Thank you, thank you, thank you. I like the practicality to which you present and make your submissions. So I want to go to Dr. Innocent now. Then right after, I'll come to Ruth on health system strengthening. So I want us to touch on policy and financing. So Dr. Innocent, what policy changes do you think we can urgently put in place to move us closer to universal health coverage? And right after that, you would want to touch on some current healthcare funding as it stands now, sustainable. If not, where can we reform some of these things? Thank you very much.
Yes, thank you so much, Dr. Jonathan, for that inquiry. When we look at policy, I think it's a very complex aspect. Why I call it complex is oftentimes from the different documents that we have seen, there is quite a lot of policies that have been drafted, but the question is what is being implemented, what is being done on ground, So I still believe, in as much as, yes, we are trying to look at policy change, we are trying to talk about policy change, there is still a gap when it comes to implementation, okay? In as much as, yes, we appreciate the fact that some of these do take time, but for me, I think priority would be in implementing, okay? Let the things that, have been fronted as action points, let them be put into action. For example, WHO recommends that a nation should have, its healthcare budget to be at least 15% of its, national GDP. But you realize that there are some countries which are still having their health budget as low as 3.5% of their national GDP, So if we still have that gap, you realize that that's where health workers are going to be underpaid. That's where health facilities are going to be unequipped. That's where some of these educational services are not going to be extended to the community. And this is eventually going to bring us into the rat race, that will go over a given point again and again and again and again. But also, adding on to that, there are some of these things which I truly believe can work when, of course, apart from increasing, funding towards, healthcare. There are some few projects that I'm engaging in currently, and one of them is looking at investment in healthcare, trying to look at the bilateral partnerships between different countries and how they can mutually invest in healthcare. These, because, of course, just like the next question is talking about, financing, we have noted that this has been one of the most difficult times in the public health arena, where there have been, changes, shifts in global funding, projects being stopped, projects being halted, some of them being, terminated for a given period of time. And this has done both good and bad, okay? Because it has done good because it has exposed how weak our systems have been, depending on so much pain for quite a long time. But it has been bad because it came in such a manner that was, like, so abrupt, in as much as there was some warning, but they are so abrupt. You imagine that a nation has been depending for over 20 years, on a given funding for some of its critical programs. But then, they get like a 4 month notice that, funding is going to be cut. Imagine that long period of time and the recovery period of time that you need to bounce back after that. So when you look at all those cuts, you're trying to look at, okay, in as much as funding for these projects has been removed, what must be done? Can we look at some political commitment? Can we really actually have the political people, because these are the legislators who allocate some of these budgets, can we have them actually increase the healthcare budget? Because at the end of the day, we will not need to start looking for, okay, which other policy can we introduce? Because it will also end in a pile of documents at the end of the day, and it will take probably like 5-10 years, to get implemented or so. So my key emphasis when we are looking at, what is the policy that we can change? The policy that we can change is let all these policies that we have drafted, let them be implemented. Okay? If we are saying that healthcare programs need to be integrated, there must be a multidisciplinary engagement when managing a patient. Let it be so. When a patient comes to the hospital, when they are having malaria, let them not only receive services for malaria, let them go and have their blood pressure checked, let them go and have, their blood sugar checked, let them go and have their eyes checked. I am talking about eyes because I work, with eyes. So it will help a lot, because some of these can actually be picked up, That's where all this multidisciplinary teamwork comes in, but also it reduces the fragmentation of health services, because when I come and, we have a comprehensive assessment of me, they can be able to catch something which probably I was not even, aware about. And probably this could put me down probably in the next 1-2 years, So that's the emphasis, that we need to have a multidisciplinary action, that these different, for example, healthcare departments need to work together. There must be a reduction in fragmentation of health services, but there must be a lot of implementation. Okay, we must not produce more papers, more policies, more of, let us do. I think for me, that would be the policy change that I would think about, that let us implement things. Let's not take 7 years after a policy has been drafted for action to be. And all these things are possible, but it's just a little bit of a political hiccup that comes in, and things will take literally forever. So to any politician, let us increase those budgets, and let us be intentional about them. And I know surely when some of these aspects are aligned, we will achieve health coverage, universal health coverage. Our populations will be healthy. The economy will thrive, because if you have a healthy population, you have a working population, which eventually brings revenue to the country, that eventually develops the entire country. Yes, thank you, and back to you, Jonathan.
Yeah.
Thank you very much. Thank you. I like the points you mentioned, that if someone comes because of malaria, the patient, and we should take advantage of that person in the hospital and just check for everything else. I think that that is a very good one.
That I think is very good point, but in reality, as you try
And
to
people might-
introduce the person to that, he will be telling you who is going to pay for all those services. All right, so let me go and come back. There. So yeah, usually
you
those are
very
some of the
much.
barriers. Even the
Exactly
few
so.
ones that they know they are coming to do within the hospital, even the malaria one, go and get the test done so that we actually know it is malaria. You're like, the way I feel, I strongly believe it is malaria. This is how I feel when it is malaria. So you just give me medicine. I don't have money for it. So yeah, sometimes it's very difficult to introduce other things that we do want them to do. I think here where I work, what we did was to introduce something for a family, which is a package, which yearly you sign on for it, and then you come for some kind of assessments. Okay, we went through the entire, should I say, within our catchment area to make these announcements. We went to these corporate institutions. I mean, they are like, oh, no worry, we are coming, we will come, it's good. Prevention is the best. That I tell you, now we are left with us doing it alone, like us, the health workers within the facility. We are the ones that are signed on to those programs. People are not coming. They are like, prevention is expensive. Why should I just come for MRI, or should I come for this within a year just to assess for this? All right. So sometimes the mindset, I think, is the problem. We have to work on their understanding on health, so that people would believe or understand why prevention is even better and cheaper than you waiting to get into the disease state. Thank you.
Thank you very much. Thank you. We have really gone past our time, so we are within the injury time, if in the football sense of speaking. But let me quickly jump to Ruth.
Yeah.
So in concluding this webinar, but I'll do a quick run through all the panelists again. So Ruth will be speaking on health system strengthening as aforementioned. So in your view, what are the biggest weaknesses in our current health system? Then right after, you would want to add, how can we meaningfully improve the quality of care while simultaneously expanding access without anyone suffering financially? Thank you very much.
All right. Thank you so much. Thank you so much. Well done to you, our moderator, and thank you for your questions. To begin, I would like to state strongly that health system strengthening is actually the way to achieve universal health coverage. So of all that we've been saying, it boils down to the fact that efforts need to be made to continue strengthening our health systems, whether it's the NHIS and them. Now, I'll say the biggest weakness we are experiencing, whether on the global front or even in the African context, is the issue of fragmentation, efforts are being made, but it doesn't really come together so well. So it looks like there's a lot of efforts being put, but we're not seeing the results because there's still high mortality, there's still high morbidity amongst different populations, you know. So looking at the primary healthcare system, which is underfunded in Nigeria, for example, we have so many primary healthcare facilities in communities, but I can tell you for sure that they are not funded enough to serve the communities where they are present in. And you don't expect that the people don't utilize the primary healthcare services within their communities, how much more their ability to access a higher level of the health facilities within their settings. So another thing is the issue of data underutilization. Dr. Innocent, before he left, talked about the fact that we don't need more policies to be written. We actually have quite a lot that has been gathered over the years. We, in as much as publications keep going out, but the truth is, what have we used those data for? I know countries like Ghana, Ghana has made some strides, which is commendable, and I would say that other countries within Africa should learn from one another, from the good example of Ghana. So I would say we should pause on the need to want to publish papers, and write policies and begin to implement those things like he really hammered on. We have wonderful policies, you read them, you feel like you're in heaven, but in reality we haven't implemented them. The communities that we promise to serve are not able to benefit from these wonderful policies that have been written on. And so that's one of the issues, the weaknesses we're experiencing. And so ensuring that we have a system where data that has been collated over the years is used to make to drive decision making in improving healthcare is critical to strengthening our health system for universal health coverage. And we talked a bit about workforce issue. I know there is a current, let's say, is an epidemic of our workforce being migrated from, our underdeveloped countries to higher income countries. It's a fact. And to be honest, I see that this is one of the biggest weaknesses that our health systems are currently facing. In Nigeria alone, the ratio of doctor to patient as at last year was 1 to 1,000, a doctor to 1,000 patients. In what good earth will that work? So when we build a health system that values our health workforce, we show them that they are valuable by implementing policies that have been written on improving their welfare. Welfare is key. The only reason why a doctor in Nigeria would want to leave Nigeria for the UK is because of welfare. The country does not provide all it needs, all he or she needs to thrive as they should. So you would want to go to a clime where your services are valued, by getting better welfare, better care for yourself, your family, and loved ones. So those are some of the issues. We find that people are training now. Once they leave medical school, the next thing is they want to write some international exams to migrate. I don't know about Ghana, but it happens in Nigeria and in some other parts of Africa too. Our doctors, our nurses, our medical lab scientists are all, being exported out of the country. So what happens? So who is going to be left? The ones that are left behind are overstretched. The schedules are crazy. A doctor is overwhelmed, and so if they are overwhelmed, how is high quality health service going to be delivered? So those are the issues. And then to go on to the next question about improving the quality and also expanding access. We cannot expand access really without protecting the quality. You are at risk of dropping the quality if you just want to increase access and increase access. Currently, I will stay with my Nigerian context and the fact that we already have so many primary healthcare facilities, for example. So instead of wanting to expand or make sure that every single community has a primary health care, why not build a system where neighboring communities are able to access healthcare in a primary healthcare facility that is close to them, that has been well funded, well equipped with the workforce that it needs to deliver the right kind of care. It's we cannot boast of universal health coverage if we neglect our primary health care. And access without quality would mean that we come up with poor outcomes at the end of the day. And after everything has been done, you want to make sure that the healthcare service you're delivering is not just going to the hospital, getting treatment for malaria, but then it is of great quality. And I would like to, would I say, lend voice to what Dr. Innocent mentioned earlier about a system where, let's say, it's an aspiration where you go to the hospital and you're able to access different types of tests, even though you came for just malaria, for example. So that will, at the end of the day, be what we aspire to. But currently, we would need to work with work in a way that we make sure that the efforts from different systems, different platforms are not just in isolation, but the efforts are integrated such that the impact is felt much more. Thank you.
Thank you very, very
Thank you
much.
so
Thank
much.
you. That's very insightful, very, very great. We would want to go all the way back to UK. Prosper. So Prosper would want to make this very concrete. And if you had the authority to implement one change tomorrow, just one, what would it be and why? Right after answering that, you would want to say something to young professionals and emerging leaders who would want to play a meaningful role in advancing universal health coverage. Over to you, Prosper.
All right, thank you so much. So thinking about what change we could make tomorrow from where we sit right now, I think there are two major changes I have classified: changes systems, little changes, and big changes. And I like the fact that Dr. Innocent was talking about policy a lot, and that's what I mean when I talk about big changes. I'm talking about policies. I also like the question because you said if you had the power or if you had the authority to implement one change, what would it be? Yes. So that brings us um, or that reminds us how change is impossible without having power dynamics in our system. Yes. So change is largely dependent on power dynamics. So we are talking politics, policies, you know, who calls the shots? Is it the expert? Is it the doctors? Is it the um, uh, nurses? Is it the patient and all who are in public health? Or is it the politician? Yeah, when it comes to uh, healthcare finance, our root stronger health system, what universal health coverage. So that's for the big changes. We should be thinking about smart ways of financing our systems, because Dr. Innocent addressed the ability of the kind of fundings that we receive to support our system, and how that cannot be all the now the global crisis in how certain fundings that we use in the global no temporary how long be withheld, we don't know. Not, but so can we think about um, smart raising uh, for support? That also um, means that we need to prioritize health. Dr. Innocent talks about the GDP is, is capped for health in low middle countries. Something not really right. And we know what not to help us achieve universal health coverage. Recently, I saw that uh, the government of Ghana trying to raise funds for the, the World Cup that's going to take place in the United States. They decided to invite certain rich, popular musicians who have the public have known to be a loggerhead for a long time. Talking about the camp of Shawali and the Stonebwoy.
Boy.
Them together, brought, asked them to hug each other, actually created an atmosphere where they could, calm down and then think about supporting sports, right? And they left the stage, each donating in excess of $80,000. Stonebwoy donated $80,000 to support the World Cup. Shatawali donated $100,000 to support the World Cup. It was like a challenge. The Stonebwoy said he was donating $80,000 because he had already used $20,000 to make a certain song which helped Mahama and the NDC come into power. So that he used 21,000 actually. So it means that adding that to the $80,000 he had donated $101,000 more. So he had donated more than Shatawale. But I think that that's on the lighter note. But I think that these are smart ways of raising money for sports from our local content. So we cannot now go and be begging the US, or now we don't have the USA funds coming in. So we can do the same thing for health if we really prioritize it.
Yeah.
That's smart ways of raising funds. That's for big changes that we need. For little changes, it doesn't necessarily take money to make the little changes that we need in our health system. So, volunteerism, for example, education. I've noticed in here in the United States that they prioritize volunteering a lot. Yeah, so we have a lot of people. I wouldn't try to downplay it. I mean, a lot of graduates who do not, I'm not downplaying the pain of finishing school, maybe 2 years, 3 years, 4 years, and not getting jobs. But these people that if we create systems that prioritize volunteerism, we could leverage on their skills, the knowledge that they have gained in school, their health workers practitioners, to be able to uh, close some of these gaps that have when it comes to education and health promotion. Again, back to the big changes that we need to make. Um, can we still on health finance? Can we think um, about monetizing certain um, services that the rich can access, or the rich can pay for, and use those proceeds to be able to for the we could also be thinking about leading the way, still on big change, leading the way. When Mark talked about the Mahama case, the free universal, the free universal, the free primary care service, he led the way by donating a certain amount of money. So can we also be thinking about leading the way in our small ways that we can in our context? I talked about how I went back to that village just to get the guy registered on NH. That's a small change anyway. And he was able to access care because of that. What can we do, um, young professionals? We be considering all these small changes, also advocating for the big change we need to see. Thank you.
Thank you very much. Thank you, thank you, thank you. So as we
I
round
like the
up,
classification.
Yeah,
A
yeah.
big
exactly,
change and
so
then a
big
small.
change, small change.
Yeah,
Very, very
very
powerful.
nice.
So I would
Yeah.
want to do a quick round as we bring the webinar to a close. In one sentence, what must we do now in the present? What can we do now to advance health for all? I would want to go to Fatih, then after I come to Prosper.
Well, for me, I think that it's been said already, but I would just re-echo is we must move from intentions,
Yeah.
right? There's been a lot of talk, there has been a lot of policies. We move from it and then to maybe equity driven actions. All right, we should implement those ones that we have, make sure that people are involved. I mean, the vulnerables are always in mind when we are doing those things, so that it promotes access, create awareness. I mean, make sure that we try to correct misunderstanding or misconception about certain illness and other things. All these things, petty ones, will all come together to make our work much more easier, and then see the clear light of trying to improve health for all. Thank you.
Thank you very much, Prosper.
Right. So there's hope for us, right? There's hope for achieving universal health coverage. If not in the next few years, there's still hope possible if we are able to do, give attention to all these areas that we've been talking. For me, I would still uh, insist on the fact that we need to be considering the small changes in our own capacity as health workers while we advocate for the big changes
Maybe
that
change.
we need in terms of policy and implementation of such policy. We also need to give attention to the areas that have been ignored long term. Yeah, Yeah, we know those areas, not a lot. Yeah, in the UK, for instance, we the much progress made in university because the focus not only on the medical model, social care model is a very important driver of achieving universal in Europe. And I think we're looking at all fronts, all these achievements that have coverage.
Thank you, thank you, thank you, thank you, thank you.
I think that for me, I have hope. I have really hope because I've already started seeing some progress. Because
Excellent.
now, as health workers, we know that we need to use community approaches, and then there are digital innovations also coming up. All right, and I think that what we it's left for us is to have that commitment. Yes, I know the commitment is there, but I think that we should amplify or make it stronger commitment to achieving the universal health coverage. And I think one day we'll be here talking about yes, we are there. Thank you.
Thank you. Thank you very much. A very big thank you, sincerely and deeply, to each and every one of our panelists for such rich, thoughtful, and actionable contributions. I must say that today's discussion has reminded us that achieving health for all requires far more than policy frameworks and financial commitments. It also demands resilient systems, genuine community partnership, and an unwavering commitment to equity. On behalf of the organizers, I want to say a very big thank you once again to all our panelists and every member of our audience for investing your time and energy in this important conversation. I must say, and it should be on record that I said it too, that the work continues beyond this webinar or beyond this panel. Let us carry it forward. Just a quick announcement that a link has been shared on the chat, and we are all encouraged to evaluate the event. Thank you so much, and have a great and wonderful rest of day. Thank you. God bless you.
Thank you
Thank you for having us. I'm happy
Thank
to be
you.
here. Yeah, thank you.
Thank you. Thank
Bye.
you.
Thank
Bye.
you. Bye.
Bye.